Hello friends, this is your surgery ka dost Dr. Rakesh Mittal, DRM. So topic for today's video is thyroid. Lots of questions asked about thyroid. Most important are thyroid cancers, the goiter, then particularly the complications of thyroid surgery, thyroid storm, nerve injuries, parathyroid insufficiency, vascular injuries and all. Okay, so most important is thyroid cancers and complications. So we'll discuss them one by one. Try to cover as much portion of thyroid as possible through these questions. First is, which of the following is true about medullary carcinoma of thyroid? So before jumping on this, let us talk about thyroid cancers, thyroid tumors. We have benign and malignant. Benign is follicular adenoma. Follicular adenoma. Malignant, the most important is papillary carcinoma thyroid, papillary, then follicular carcinoma thyroid. Third is medullary. Basically 80 to 90% is this, 80% roughly you can say, right? This is 10%, 10%. Rest you can keep it in 1%. Then you have anaplastic cancer, and last the least important is thyroid lymphoma. The first three are the most important, so we'll discuss them. We'll have questions on papillary and follicular later on, but in this one we'll focus on medullary carcinoma thyroid. The first two, papillary and follicular. Papillary is the most common thyroid tumor. I told you 80 to 90%. Medullary carcinoma, it's a tumor of parafollicular cells. Origin is parafollicular cells, also known as C cells. You know the thyroid structure, follicles, follicular cells, where the thyroid hormones are synthesized using thyroglobulin, the precursor protein, and the using the enzyme thyroperoxidase and iodine as the raw material. Okay, so the papillary and follicular cancers are the tumors of follicular origin. They originate from the follicles. Now, around the follicles, between the follicles, the cells, C cells, that's the origin for medullary carcinoma thyroid. First and the foremost important question about it. C is for calcitonin. These cells, it's a calcitonin secreting tumor. They produce so high calcitonin. Okay, so medullary carcinoma, it can be familial, it can be sporadic. Familial is more aggressive, more seen at younger age, more metastasizing. Sporadic is less aggressive, old age, better prognosis. Familiar has a poorer prognosis. Now, second most important point you should know is RAT proto-oncogene mutation. It's hallmark of medullary carcinoma. RET proto-oncogene mutation. Then histopathology, amyloidosis. Deposition of amyloid, that's another hallmark. Important points I am telling you. Okay? Let us see the questions now. Which of the following is true? Associated with MET oncogene? No, it is not MET, it is RET. Elevated levels of serum calcitonin? Yes, true. Now, not just the calcitonin, it also produces other hormones, paraneoplastic syndromes, right? calcitonin gene related peptide, CGRP, calcitonin gene related peptide. It also produces serotonin that can be responsible for diarrhea associated with medullary carcinoma thyroid. It can also produce carcinoembryonic antigen, prostaglandins. Okay. Seen in men 1 syndrome, multiple men is multiple endocrine neoplasia. Men is multiple endocrine neoplasia. There are three syndromes: men 1, 2A, and 2B. So, men 1 syndrome does not include thyroid cancer. It includes pituitary, pancreas, and parathyroid. This will discuss in details. Don't worry, all the men syndrome. Later, I have a question on men syndrome. So, it's not part of men 1. Medullary carcinoma is part of men 2A and 2B, not 1. Most common thyroid tumor? No. Most common is papillary carcinoma. So, correct choice, I have told you. Now, this is straightforward. We have already discussed another question: medullary carcinoma, thyroid. RET proto-oncogene mutation is a hallmark of. Okay, this is a question recently asked in INI CET, even the previous one. 22-year-old medical student presents with exophthalmos, palpitations, and heat. This is thyrotoxicosis. Clear, straightforward, palpitations, exophthalmos. The picture also you can see exophthalmos, staring looks, eye signs. All of you must have read in details. Now, question has been asked: which antibodies would be elevated in this clinical condition? In Graves disease, Graves disease, which is nothing but a primary thyrotoxicosis. Primary thyrotoxicosis. You know the triad of this: signs and symptoms of hyperthyroidism, the ophthalmopathy, the pretibial myxedema. This is medicine. I'm not going into detail. Now, what is the primary cause? Autoantibodies. What autoantibodies? Against the TSH receptors. This is the antibody which is bodies which is seen in Graves. TSH receptors, autoantibodies against TSH receptors. They bind to the TSH receptors and they have a stimulatory effect. These are IgG autoantibodies. They are also called LATs. Remember this term: long acting thyroid stimulator. So they have stimulatory effect. They bind to the TSH receptors. They stimulate the production of T3 and T4. Increases long acting. So that leads to thyrotoxicosis. This is the mechanism of the pathology. So anti-TSH receptors. Anti-TPO are seen in Hashimoto's thyroiditis. Anti-thyroglobin also seen in Hashimoto's thyroiditis. This will discuss later with Hashimoto's. Question on Hashimoto's. Now next is question on thyroglossal cysts. Again a clinical question. 3-year-old baby girl presents with a swelling in 3-year, swelling in front of the neck. Thyroglossal cysts, the classical age is 2 to 4 years to begin with. They can present later in life also. First notice, forget about swelling. This is it. Swelling moves on swallowing. So it can be a thyroid swelling. And also on protrusion of tongue. Now here it goes a different way. There are two swellings in front of the neck which are very common. Thyroid swelling, one the most common. All thyroid swellings move up on deglutition, swallowing. You should know the reason. Because of that pretracheal cartilage attachment with the larynx. Now, on protrusion of the tongue, thyroid swelling